Is it sensible to make mental health services accountable for homicide by their patients? Let me begin with a quote from David Clarke in his book about the history of Fulbourn Hospital, the psychiatric hospital in Cambridge in England. Much has happened since 1983, which is when he retired. The number of people in mental hospitals over Britain has continued to decline. The attitudes of denigrating public service, of running down public hospitals, building up private enterprise, and of mean-minded economising have filtered down through the NHS bureaucracy. Battered by public inquiries and outcries, pressured by harassed ministers, the administrators and managers have reverted to the kind of administrative behaviour that marked the worst of the asylum days, issuing memoranda, forbidding activities, putting up warning notices, setting up disciplinary inquiries, and penalising staff who take risks or show initiative. Staff have learned to be cautious, to get everything in writing, to avoid initiative. I want to look at this state of affairs in a bit more detail. The numbers of people in psychiatric hospitals increased until a peak in the 1950s in the UK and USA, and later in other countries. The motivation for community care was said to be the dismay and disgust with the old asylum system. The damaging effects of institutionalisation became recognised, and the hospital was promoted as a therapeutic community. The rundown of the traditional asylum was not without controversy. Many psychiatrists felt threatened by their perceived loss of power due to the rundown of the psychiatric hospital. And campaigning organisations deliberately exploited public anxieties and criticised government policy on community care. Their initial concern was that homelessness was being increased among the mentally ill. The political tack changed when academic evidence accumulated against this view, at least in the UK, to concern about public safety due to homicides by psychiatric patients. In 1997, the government decided to focus on public safety and declared that community care had failed. One advantage of this position is that debates about community care are no longer as polarised as they were in the past. Inquiries into mental health services have had a role in this political debate about community care. In the 1960s and 70s, several scandals came to light that uncovered mistreatment of patients in hospital. Inquiries have now shifted their focus from abuses and over-restrictive practices within institutions to anxiety about the lack of control in the community. Homicide inquiries can have devastating consequences for mental health services. One problem is that they reinforce the stereotype of the dangerous lunatic. The danger is that public fears of the mentally ill are fueled. Lukewarm Luke, formerly Michael Fawkes, stabbed to death Susan Milner in 1994. Michael Fawkes had changed his name by deed poll to Lukewarm Luke, apparently taking the name from a character in a TV programme. He had been diagnosed as suffering from paranoid schizophrenia and had been in and out of mental health facilities. He was released by a mental health review tribunal against advice on the condition that he continued to take his medication. However, he later refused to take his depot injection and was allowed to take his medication orally. The inquiry team criticised the lack of communication in the community care team dealing with the case. The three members of the aftercare team did not meet together in the 25 months leading up to the killing. They also criticised the decision to allow lukewarm Luke to discontinue his depot medication. Despite the length of the report, it is unclear why lukewarm Luke killed Susan Milner. The only explanation offered is that he was schizophrenic. This is regarded as a sufficient and complete explanation. There is no questioning of this connection. The simple, almost naive view is that schizophrenia is a biological illness that determines how a person behaves, especially if they are violent. Any court exercising its proper role would never let a forensic psychiatrist get away with such an oversimplification. Yet inquiries can produce authoritative reports based on this kind of assumption. Lukewarm Luke's history of serious violence, which antedated the illness, was passed over without comment by the inquiry panel. Furthermore, the focus on mental health services tends to exclude the role of other actors in the drama. For example, lukewarm Luke's victim visited the patient at 3 a.m. despite advice from friends not to do so. The preoccupation of many inquiry panels with apportioning blame has limited the lessons that could be learned. Understanding complex cases requires an approach that goes beyond blaming. As another example, I want to look at an inquiry from my own NHS trust, the Richard King inquiry. Richard King was convicted of the manslaughter of his mother-in-law's partner in 2004. He had been known to mental health services in Norfolk since 1991. The trust internal panel concluded that the homicide occurred because of his mental illness, and that although it was not predictable, it was preventable, because he should have been detained under the Mental Health Act. It is clear that the trust panel was motivated by what it understood as the public expectation that mental health services should exert some control over the behaviour of individuals in their care. The report was written to maintain this public confidence in mental health services by identifying mistakes and errors of judgment. However, it is not necessarily the role of an inquiry report to meet these stated public expectations. If this were the case, it would mean that homicide inquiries were being used to achieve political aims. The report did not demonstrate that staff acted in bad faith, nor without reasonable care. These are the criteria that should first of all be used to assess their actions rather than mistakes and errors of judgment. No professional system ever works perfectly. There will always be weaknesses. The panel report, like other homicide inquiries, was also written with the benefit of hindsight. Nor is it as clear as the panel makes out that detention under the Mental Health Act was indicated. Compulsory treatment is only necessary if treatment cannot be provided unless the person is detained. Informal admission without the use of the Mental Health Act seems to have been a viable alternative to detention in this case. As is required by Department of Health guidelines, there was also an independent inquiry undertaken by the Strategic Health Authority. The independent inquiry came to very different conclusions from the Trust internal inquiry. It also expressed concern about the professional consequences for Trust staff who had been caught up in the Trust inquiry and had had their competencies questioned. However, it concluded that no individual and no single act or omission led directly to the killing. It went on to say, on the balance of probabilities, better quality care and treatment would have substantially reduced the increased risk of a violent act. However, it concluded that the frenzied killing could not have been reasonably foreseen. The independent inquiry could not agree with the conclusion of the Trust internal inquiry that had Richard King been detained under the Mental Health Act, he would probably have spent longer in hospital and would not have been given early home leave. Furthermore, it went on, the relationship between the factors described in the report and the homicide was cumulative and complex. There was no simple, direct, causative link. No single individual can be held responsible. gone into some detail about these reports to emphasise that homicide inquiries do not always get things right. They may be subject to as many errors as the service they tend to criticise. I want to move on to look more generally at risk in mental health. Homicide inquiries have made modern mental health services defensive. We live in what has been called the risk society. Someone has to be blamed for misfortune. As we have higher expectations of what can be achieved, our increasingly technological society switches this blame onto services provided by society that it thinks should have prevented a misfortune. However, it is always a political question about what is acceptable risk. In particular, there's a debate about the balance between risk-taking and risk avoidance. If anything, what the risk society means is a shift towards the risk-aversive end of this relationship. The word risk has been preempted to mean bad risks. The promise of a good political outcome is couched in other terms. Yet overcautious behaviour can be counterproductive. Taking risks may be an opportunity for growth, not just something to be avoided. Actually, we have very little reliable knowledge about the accurate clinical quantification of risk. Merely knowing about risks, even if these could be calculated, may not necessarily improve practice. And belief in actuarial risk prediction can actually lead to fantasy estimates that may well have an aura of factuality, but in fact are misleading. To give an example, I want to look at community treatment orders. The notion is that deaths by homicide and suicide are avoidable by increased coercion. A guiding influence in UK government mental health policy over recent years has been the National Confidential Inquiry into Suicide and Homicide by People with Mental Illness, which collects data on deaths by suicide and homicide by psychiatric patients. In one of its reports, the inquiry went as far as to estimate the potential number of deaths that would be prevented by the introduction of community treatment orders. This relied on making various assumptions. It could have produced a higher or lower figure, dependent on different assumptions. The fact is that whatever figure was produced is not evidence of the value of compulsory community treatment, as it is only an estimate calculated if this intervention is effective. There are too many variables to make an accurate estimate of what will happen in practice. We need to recognise the inherent uncertainty in clinical practice. However much we may wish it were the case, guidelines and procedures cannot eliminate clinical judgment in the management of patients. Healthcare is more than a case of following rules and procedures. In fact, greater consistency and invariance cannot cope with the unexpected, and the heroes that do prevent tragedies have usually thought outside the box. The danger is that we go along with the illusion created that we can be effective in preventing all individual tragic outcomes. If we become too defensive, the fear that things may go wrong actually distracts us from the task of how to make things better. And we become motivated to follow procedures more for the purpose of protecting staff than helping patients. We need to regain our common sense. Accountability is a good thing and needs to be applied sensibly. Any improvement in services needs to be authentic and related to the quality of care, and not a facade for placating society's fears. The fear of being criticised and unfairly judged can have a negative effect and does not lead to creativity. Staff need to be supported, not attacked. Excellent clinical leadership provides an ethos where staff are valued and supported to gain the most out of them in the interests of patients. In summary, I've tried to show how we cannot avoid relying on professional trust. Our assessment of risk in society has seemed to create the possibility of a rational risk governance, which is in fact an elaborate technocratic fantasy and a bureaucratic defence against the anxiety of disorder. Actually, psychiatry should have known this because of its history in the asylum. Opening the doors of the asylum was